So we'll just talk a little bit about my approach. I want to call my, the signature approach. And as I've explained already a little bit, this is this understanding, this biopsychosocial understanding, this model of illness and health that was first suggested by American physician George Engel more than 40 years ago. Engel even then was concerned that we were getting too caught up in the science of medicine, and we were forgetting that these were people coming in to see us, real people with real-time problems that were complex and complicated, and they couldn't just be reduced down to a single tissue or a single cause that could be easily fixed. Engel suggested it was necessary to consider the whole person, and not just the whole person, their internal environment, their thoughts and beliefs and expectations, but also their external environment, where they lived, where they worked, what levels of social support they had, as well as understanding their description of their pain, their description of their disability, and that this should all be done simultaneously by the clinician. One of my problems with the way that we've now adopted this model is we still tend to divide people up. If we think a person has got an issue with anxiety or depression, we tend to send them to the psychologist, to the interventionist if there's kind of discrete spinal pain, to the occupational therapist if they're having trouble at work or at home. So despite Engel's model being accepted by the International Association for the Study of Pain as the best and only way to think about chronic pain, we're still tending to divide people up into segments and try and shuffle bits off to different people to help them understand. And this, I really do believe in what Engel said, should be done simultaneously, because it's quite difficult to understand whether it's the biomechanics of the pain or the person's response to the pain, or indeed the lack of belief or social support that they feel that they have around their pain, which is contributing to it. The important place to focus is on those three intersecting circles there, because where all these three circles intersect is where health and well-being exists. But when they get out of kilter with each other, this is also where illness and disability can lie. We need to consider the mind and body as one single unit, not breaking it apart into different parts that was first suggested in the 17th century by a famous scientist who thought that the mind and body were completely separate. As we'll begin to see, this is clearly not the case, and it makes no logical sense. And in fact, it's known as Descartes' error, because it was René Descartes, the French philosopher, who suggested that the mind and body were separate. We need to think of these things all intersecting. The second piece of information that maybe comes from this biopsychosocial approach to understand is that chronic pain isn't just a simple one-way street. When I first started my pain training, we used to consider that people with long-term chronic pain were basically people who were suffering with depression, which was now manifesting in their body. But we now know that people with chronic pain can end up feeling depressed, and why wouldn't you feeling that way when you're dealing with the ravages of pain on a day-to-day, hour-to-hour or minute-to-minute basis? Doesn't matter which end of this street you come in, people end up in the middle of the street sounding exactly the same. Pain takes away our ability to enjoy life, takes away our ability to do the things that we want to do. It impacts on our relationships, our sleep, our libido, our appetite, our ability to concentrate and focus. We lose motivation. And this is one of the big problems in all of these areas, is that it becomes very hard to push back. Because for many people, they've pushed back long and hard and not necessarily got anywhere. And this approach takes a slightly different route than actually pushing back against the pain or dysfunction.